Hi, this is Aaron Cook coming to you from Physical Therapy and Balance Center in Mentor. We are on location with Dr. Sarah Curtis of Sounds of Life Hearing Center. This is our first Ask an Expert section. So I'm very excited to have Sarah here. She's going to be the first one. We've been meeting at a couple of local events, and she was very fortunate to give me her time and let me find out all things audiology.
Okay.
So icebreaker question. I was going to say this till the end, but I think this might be the most
Okay.
important question that I'm going to ask you.
Okay.
Do you say tinnitus or tinnitus?
Both are correct.
Both are correct.
It's
Okay.
not tetanus, tendinitis, or tinnitus. I have people who tell me they have tetanus in their ear and I want them to go get a shot.
Oh my goodness, that's hilarious.
But tinnitus tends to be how a lot of audiologists
Mhm.
pronounce it, but and tinnitus is general public, but both are correct.
Fantastic,
So,
fantastic.
yep.
So I want just like a quick just background on Sarah Curtis. I understand you're from the Lake County area.
I grew up in Painesville and moved to Mentor, and I
Hmm.
graduated from Mentor High School. I went to Youngstown State and got my Go Penguins and got my undergraduate in psychology. I was actually started as a music ed major. Music is really important to
Really?
me. I'm a flute player, and I like to sing. But then I decided I didn't want to do that. So then I spent a year volunteering with the AmeriCorps Vista program. And then I was in Knoxville, Tennessee doing
Hmm.
that. And I decided to stay and I got my graduate degree in audiology from there.
That's fantastic.
So I practiced first in Central Florida at a nonprofit speech and hearing center. And then I moved up here, worked for university hospitals for a little bit. And then in 2018, I opened my private practice.
So I'm so curious about what prompted you to open your own clinic? What did you see in the community or in healthcare in general that made you want to branch out and go solo?
Yeah, so I mean, and this is no offense to the system, but in when you're in a big hospital system, or I actually spent a couple months working at CVS when they had hearing centers briefly. Um, the bigger the system, the harder it is to make change. And I'm a mover and a shaker, and I like to do a lot of continuing education and a lot of reading and a lot of learning from my colleagues across the country and internationally. And so when they introduce new concepts or when new evidence comes out that a new test is going to test something way better than before, I want to implement that.
Mm,
And that's really hard to do when you are in a larger organization because of the nature of the beast. You have to get in agreement with the rest of your team and everything. So, um, I got to a point where I just said, I want to do things the right way, the best way, and I want to be able to change on a dime if the industry changes. Also, I love to do outreach. And when you're in a private practice, you can do that. You
yes.
can go out, you can choose your path and drive it that way. Um, and so I wanted to build a practice that was all around doing the right thing and doing the right thing at the time that it's appropriate to move forward with change and different things. I wanted to be able to educate my community, and one of my goals was to be the place where every patient wanted to go, every person wanted to work, and every student wanted to come and learn. We're a teaching practice. So, and I'm getting to do all of those things. And so it's great.
That's a fantastic answer. That's You literally just described why I do what I do. So
Yeah.
thank you for that. I'm curious if you had, if there's any healthcare workers listening to this that are on the fence about, should I go into private practice? Should I do this? Is there anything you would say to them?
I never set foot in a private practice until I opened my own. So,
It's funny as I'm the same way.
and I just I think I always felt like I had to, they say, like, sell your soul to your practice. And I mean, I am somebody that thinks about work all the time, but I did that before I owned a private practice. But I also feel very strongly about work-life balance. And so I was able to set this up in a way that works for me, that works for my family. Um, I certainly think I was fortunate that I was mentored and in a wonderful, they called it a mastermind group
Mhm.
of audiologists starting new practices. And we had a mentor, and we met
Oh,
every other week for 3 years. And so it was really wonderful to have colleagues that were in the same position and trying different things and kind of working those problems out together.
that's so valuable.
Yeah, and even
It's
now we've ended that group, but we all still talk every
I'm
day.
sure you get happy hour or
Oh
Zoom calls
yeah.
or something
We're
these
we have a
days.
Facebook group and we just all day.
Oh, that's so helpful, so
So,
helpful.
yeah.
So what kind of backing up a little bit, what drew you to the field of audiology?
It was an accident. I just really didn't know what I wanted to do. So when I was in Tennessee, I looked through the graduate catalog. I was like, oh, speech pathology looks cool.
Hmm.
So I was going to be a speech pathologist. I had to do a full year of kind of undergraduate courses in communication sciences before I
Hmm.
started my graduate program, and because I needed the prerequisites. So I found that I loved my audiology classes more.
Hmm.
And we might talk about this later, but my ears were ringing, and I don't know when they have it in my life. And we started talking about tinnitus in class. And I went up to my professor afterwards and I said, "You mean not everybody's ears
Oh
ring all day
no.
long?"
Oh no.
And I was like 23. And he said, "No, and you should probably get a hearing tested in our clinic." So I did. And anyway, it's all uphill from there, you know? So I call this
Life always happens for a reason, and
it's my soulmate profession. Have you ever heard
what
of
is
the
that?
term ikigai?
I have not.
So it's this concept of, you need to be doing something that you love, something that you can make a living doing, and something that like serves the community. So like has a greater purpose. And if you have all three of those things, it's called ikigai.
I've never heard that term. I've heard different people in the public space make that
I
same
think that's what
point.
it is. I might be using the wrong
Ikigai,
random
I
word,
love it. I feel it's
but
not a real thing. We're coining it
right.
today.
So, but I'm so fortunate to have that. And I found it by chance. So
Did any of your music background help you in the field of audiology? You said you're a flutist.
yeah.
I don't know if you have perfect pitch or anything like
No,
that. Is that
but I do have a good sense of intonation. It makes me, I think, a little bit better able to work with musician patients because hearing aids, when people have hearing loss and they're a musician, hearing aids can do strange things with volume and pitch. They can affect dynamics, which is like the appreciation of loud versus soft in music. It can kind of make that difference less. But for a musician, you want to hear those differences. So there's certain things that I understand about music that I think allow me to think about the changes that we're going to make or the products that we might choose or the strategy or the prescription that we would use to fit the hearing aids.
it's interesting you mentioned working with so many musicians with hearing loss, and
Hmm.
we're in. Is this technically Paynesville where you're
It's
located?
Concord Township.
Concord, Concord.
Yeah.
I was like, it's kind of that Menor Paynesville
Yeah.
Concord area. I'm not sure where it
Yeah.
falls, but it's not like we're in New York City or Nashville, Tennessee. Do
Right.
you see a lot of musicians in this area?
I don't see like professional musicians. I have in my career seen like percussionists. Drummers have horrible hearing.
Hmm.
If your kid's a drummer, they need to have hearing protection. Come talk to me.
We're going to talk about
but
that.
but I see like I have one patient. She has been playing the piano for years. I have a lot of patients who don't necessarily play, but they love to go to the orchestra.
Right.
I have another patient who's an organist in her church. And so appreciating those things. I have one woman, she plays the bells like in a bell choir.
Hmm.
Those are awful for hearing aids in general. So I had her when we were trying a couple different hearing aids bring the bells in. We can't always do that,
Right.
but she could bring the handbell. And we listened to a couple different hearing aids until she found one that didn't distort the sound. So
That's fantastic.
yeah.
I didn't even think about that.
Yeah.
So we've kind of already set up our own. I was going to talk about tinnitus or tinnitus a little bit later, but we've kind of been kind of dancing.
Yeah.
Oh no, we're kind of dancing on that topic. So let's, I always think of, I have a lot of patients as a therapist that have the ringing in the ears or the
Mhm.
tinnitus, which is what we're talking about here. And it makes no sense to me pathophysiologically. Like okay, if somebody breaks their leg, I can say, okay, well, that bone was supposed to go like this and now it goes like this.
Right.
I can see what's wrong. I have no concept of what happens in the body during tinnitus or tinnitus.
We don't know either exactly what's happening.
Mm-hmm.
We do know that it's highly linked to ear damage. So about 80% of people with hearing loss have tinnitus.
Okay.
But about 15% of the general population without hearing loss has tinnitus. And maybe they're like me and they were 20, 30 before they realized it was abnormal. So we really don't know how many normal hearing people. I have completely normal hearing. But we do know that there's a link between damage to the ear, because there's a huge correlation between hearing loss and tinnitus, between damage to the ear and tinnitus. We know it also because it's more predominant in people who have a noise related trauma, an acoustic trauma. So like individuals who have been around firearms, veterans, there's a really high incidence of tinnitus.
Is there a certain decibel that they know is, prolonged to, 100 decibels or whatever number that is? Is there a recommendation there?
Yeah, so for noise damage, the cutoff point is 85 decibels hearing level. Okay, and
I'm going to be honest. I threw out the decibels like I have any concept.
No,
of what sound is what
you're
level.
good.
Like
you're
with
good.
85 decibels, is that like a tractor? Is that like?
It's I'm trying to think what some good cutoffs are. Like lawnmower, okay, is a little bit louder than 85.
Okay.
Pardon me. So lawnmowers, people don't think about everyday objects, but even if you hit the right material with a hammer one time, that can be loud enough to permanently damage your hearing.
Okay.
Like
one
I said,
time, is it?
You can have a single incident of noise exposure that causes permanent hearing loss.
I suppose that makes sense in the context of veterans or in the context of it.
There's also a genetic predisposition to noise-induced hearing loss.
Okay.
So it's kind of like you'll see in one family, like a lot of people get cancer, and then in another family, people don't if they get the right triggers, one versus the other. You can have somebody who smokes for years and doesn't get lung cancer, and another person who does. So even though, for example, the smoking might be a risk factor for lung cancer, in one family, they're not genetically predisposed as much as the other. You don't know, though. That's the problem. And so with noise-induced hearing loss, it's the same way. You might have everybody in one family, who's ever worked in a noisy place or had noise exposures. You test their hearing and you see they have a hearing loss. It's very suggestive of noise-induced. Whereas you can have somebody else who's worked in a factory for years without hearing protection, and they also, shoot guns recreationally and all this stuff, and they have perfect hearing. So, but I would always just assume you're on the other side. I would assume you have a genetic predisposition. I would assume you don't have superhuman hearing and protection in your ears, and use hearing protection, because the hair cells in the ear, once they die from that noise exposure, they do not grow back.
Is there a certain age that you would recommend starting hearing protection, or is that just kind of a universal precaution?
Birth. Yeah, I think, there is strong enough evidence that shows that noise exposure can damage hearing in anybody. So we need to be thinking about that through our entire lifespan. And I have patients who have hearing loss and they say, well, I'm not going to lose any more hearing. I'm like, the heck you're not. You can still lose it. So yeah, everybody needs to think about hearing protection.
So I should start wearing earplugs when I go to concerts. I went to far too many concerts in my younger days, and I got right down in the pits and in the front row, some really loud bands, and it happens every day, every other day. I'll just get 30, 62 minutes of just that ringing in the ear.
And it could be related. It could be just idiopathic, so no known reason. But you also could have a little bit of damage to your inner ear cells. And we have equipment here to test the function of the cells without that may show some damage when the hearing test is normal too.
So that's kind of a great segue just in talking about what all does an audiologist do? I think the general public may think of an audiologist, they may think of, maybe hearing aids or hearing loss. But
Right.
what are some of the common tests or the common treatment interventions that you're doing for, say, tinnitus or for some of these other conditions?
So one of the first things I want to point out is that if you graduated after 2007 and sometimes earlier, you have to have a doctoral degree to get licensed as an audiologist. So I actually have 9 years of post high school education under my belt. um, so we're very well educated in the areas of communication disorders, in addition to hearing loss, anatomy and physiology of the ear, neurological impacts of hearing loss, also vestibular, so balance, inner ear balance system. And we are the top professionals when it comes to the identification and treatment of hearing loss, rehabilitation of hearing loss. If you have a medical condition, we would send you to an ear, nose, and throat doctor, or in some cases, your primary care doctor. But when it comes to actually diagnosing a hearing loss, the audiologists are the best trained to do that and to make a rehabilitative plan for treating that. Some audiologists in across the nation also specialize in vestibular, so they do balance testing. They do uh, some types of rehabilitation as well. Some work in concert with physical therapists. Audiologists also, so tinnitus is something that some audiologists work with. Uh, there are audiologists that see pediatrics, some that see just geriatrics, some that work in educational settings. In our practice, we pretty much see everything except balance. So and so we do work with hearing aids. Not every audiologist works with hearing aids, but we kind of are very good and specialized in that here. I'm very passionate about hearing aids being utilized as a treatment device. Our audiologists are not commission based. We don't push to sell hearing aids. Hearing aids have a cost because they cost us money, but our services are where we put the value.
When you say as a treatment aid, do you mean use temporarily to improve function and then get rid of, or do you mean as like a training wheels? I'm curious.
So there are certain people that fit hearing aids that are trained specifically just to test hearing to be able to program a hearing aid.
Okay.
They do not have training in rehabilitation of hearing loss. In our case, what we're really focusing on is using the hearing aid as a tool to amplify speech and other environmental sounds so that the patient can then use that information to then better communicate with others. There's a wonderful audiologist who says that the ears are the doorway to the brain.
Mm-hmm.
And so the hearing aids, open the doorway. So the door is shut when you have hearing loss, and you have to open the doors in order for the information to get to the brain.
I love that analogy.
And so that's our job, is to open the doors and get that information through to the brain, because the brain is the real powerhouse that does all the work. We have to get the ears up to par, which sometimes we can't do, but as best as we can, so that the information can then go to the brain where the real work is done.
So that kind of segues nicely into another question I was going to ask you. I always think of there's two reasons people do something. It's either they want something positive or they don't want something negative.
Yeah.
So I'm sure, you've worked with seniors. I'm sure most of the older men that you've worked with, not very stubborn. They're very agreeable people. And they come to audiology of their own accord, I assume.
Yeah.
If a patient like that is listening, what can we tell them? Why should you get a hearing aid? Why is this so important rather than just so you can hear your wife better? There seems to be an attitude of, what could improve, or what could really go bad if you do not do this?
Well, let's start with some of the unwanted side effects of hearing loss. So hearing loss has been known to be associated with social isolation, depression, anxiety. Um, it can cause a lot of friction in relationships. It can cause people to pull back from doing things they love. The amount of patients that I've met who said, I just don't go to church anymore because I can't hear the message. I've stopped going to the theater because it all sounds garbled. Um, so there, it causes a huge pulling back. Even more important, in my opinion, and coming from a psychology background, I really nerd out about the brain. But we now know that of the factors of dementia that we can impact, we can't impact our age, our genetics, or our gender, but we can impact um, our biological gender, but we can impact things like diabetes and hypertension and lifestyle things like smoking and exercise and diet. But so Franklin is a researcher at Johns Hopkins, and he did this big study that looked at all these different modifiable factors for risk factors for dementia. Hearing loss was the number one. It had the most impact of any other factor, isolated, hearing loss isolated. And so we know that the hearing loss is impacting our neurological ability.
So if somebody's listening to this, they can tell their loved one who's been on the fence about getting a hearing aid, or who's been saying, what really loudly for 5, 10 years.
It's really good for your brain to hear
It's
better.
really good for your brain.
And the earlier, the better. So it's most impactful in midlife. So we get a lot of people who are 75, 80 coming to us for the first time. We want to see you in your 50s and confirm the hearing is normal then. We want to have a baseline because most people haven't had hearing tests since childhood. So we want to know what your normal is. Is your normal temperature 98.6? You've got to know your average, right? Within the past year. Almost nobody has 98.6. Most people are around like 97.
That's great.
So the adult normal is 25, but that's the upper limit of normal. If you have a normal of 10, the higher the number, the worse hearing. If you have a normal of 10 at 10 years ago, and I test you now and you're at 30, that's a 20 decibel hearing loss. Okay. But if your normal was at 20 and now you're at 30, that's only a 10 decibel hearing loss. So that gives us trajectory of potential worsening of hearing loss, and it tells us degree.
Out how long is it going to be until you're going to have maybe not understand 50% of your conversations in 7 years.
Not exactly, but we can at least know if it looks like it's progressive.
Okay.
We can at least know how far you've deviated from your normal. And that's important. So, but more important than that is we have kids, yeah, right? And if they have something going on, you want it diagnosed as early as possible so you can have early intervention because that gives them the best outcomes.
Correct.
It's no different with adults. The earlier, and I'm sure you've seen physical therapy patients, the earlier you find the problem, the earlier you intervene, the less chance it has to have a bigger impact on your overall life.
There's an interesting stat that I heard, or a common phrase, and it's always stuck with me. And it said people are more likely to give prescription medication to their pets than they are to themselves. And there's something about, taking care of ourselves or taking care of our own needs where we often neglect some very important things on our personal side in service of helping other people.
Right.
But sometimes it's important to take that big step back and say, no, I have to be able to hear so my brain can function, so I can take care of my wife, or I can be there for my grandkids or my kids, as the years go on.
Yeah. So there is beginning to be more evidence that hearing aids, they're not going to stop someone who's naturally going to get dementia from getting dementia. But there's good evidence coming out now that is showing that it can slow the decline into it. So it can kind of stave off that drop.
That makes
for longer.
Sense to me.
You're not having the auditory deprivation. You're not straining so hard just to hear what somebody said. You can actually sit back and understand it because the hearing aids have turned the volume up for you. And then you can sit back and learn. And so we want people's brains learning, not straining.
Now, I saw on your website, and I was preparing for this, and I saw something and I was like, man, I really want to know more about that, but I
Hmm.
don't want to find out until I talk to you about it.
Yeah.
I have it on my notes, but I don't want to look at it. And
Okay.
you offer a service, if I'm not mistaken,
Yeah.
um, and something to the effect of incorporating hearing loss with a cognitive
Hmm.
assessment.
Yeah, so we have, so first of all, Dr. Kara Donovan and I, Kara's our other
Yeah.
audiologist, have undergone specialty training in something called the CogniHear program.
Yes.
So there's an audiologist who has really put a lot of time and effort into developing training so that audiologists better understand the brain and the auditory brain connection and how to test and rehabilitate hearing loss to pick up on those subtle problems. The other thing that we integrate is something called the CogniView. So the CogniView is a 10-minute screener. It's really like a 4-minute video and a 6-minute test. You just move a little joystick and it's able to assess someone's kind of base cognitive status at a screening level. And it's a very good test for mild cognitive impairment, which is kind of like it gives you a green, yellow, and red. So green is great, you're doing well. Yellow is hold up. Maybe we should talk to somebody. Maybe there's certain actions we can change. Some of those modifiable risk factors, maybe we can change that. And then red is we probably should have already had you evaluated for some of this. But it's a great little tool. It gives the patient a printout. We offer this currently at no extra charge to patients coming in for a hearing test to give you a little snapshot of what your brain is doing in areas of visuospatial ability, memory, executive function, which is like problem solving, and then also your processing speed and reaction times to information. Easy. And it doesn't rely on you having to hear. How many of our seniors go to appointments where they say, okay, repeat these words, ball,
Right.
door, cat? What if the patient had to struggle so much just to hear those words that remembering them couldn't even enter into their thought pattern because they couldn't hear them? And these physicians aren't doing hearing screenings to make sure the patients could hear those questions in the first place.
That just seems like such an underutilized service. In another life, I worked in an acute care physical therapy,
Yeah,
and the big role in acute care PT is safe discharge plan.
right.
And we would always have, some people it's like, okay, clearly you can go home, and certain people it's okay, we need some rehab for you.
Yeah,
But there were always these people that would fall in the cracks, and we would see it like, this is early, this is clearly early dementia or something, but it's not so severe that we can do anything about it. But it's severe enough that we're concerned, and we want to find interventions, and we want to find ways to, get these people the right treatment, just so we
yeah.
can do what's best for everyone. So that's something where the role of audiology in terms of cognition is something where I think is really interesting. I think
Yeah.
audiology and speech I think would overlap or compare nicely together.
Yeah, so it technically is under a recommendation that speech therapists should do a hearing screening before they're doing the speech therapy,
Weirdly,
but it's not something that gets followed, unfortunately, or enforced. And it's nothing against a speech pathologist. They often just don't have the tools or the resources to do that.
mm,
But so we are trying to, my grandfather's actually in acute rehab recovering from brain surgery right now.
goodness.
And I make sure his hearing aids are in. I have a big note that says, make sure your hearing aids are in. So when you're going to OT, PT, speech, that you can hear what's going on with you, and that the staff knows that he's supposed to be wearing his hearing aids, because why are you doing these things if he can't hear you properly?
And making sure the batteries are charged is almost a
Exactly.
full-time job. I can't tell you how many times I've gotten a patient down into a rehab. We're halfway through PT, and it's like, are you okay today?
Right. Nope, their
I said
batteries are
2 months.
dead.
Oh, and then you start hearing the feedback, and
or
oh wait, this battery died. Let's go
or
change it
something.
out.
Yeah.
Yep.
So it's just really important. I think sensory information is so critical and so undervalued. Same thing with vision. And then when you have a patient who has combined vision and hearing loss, it's not additive. It's not like 2 + 2 is 4. It's
It's
exponential.
exponential.
What I work, and I have experience in pediatrics with deaf blindness. I did my research on Charge syndrome in graduate school, which has a lot of combined sensory loss. But I took that and tried to learn a lot about dual sensory impairment. That's what they call like deaf blindness in an
Mm.
adult. And when you have hearing loss and vision loss, I think it's really important to look at what's more easily treatable. So some patients have a hearing loss that is aidable quite well, but they have glaucoma or macular degeneration, which are really at some point it's just degenerative, you know. And so we have a better chance there of enhancing their hearing. But there might also be some patients who have types of hearing disorders that really, even if we aid their hearing, they're not going to understand very well. Well, then if their vision is enhanceable, we've got to bring that up because they've got to balance each other out. And so understanding the connection between the senses and understanding your role as a rehabilitationist, your role in how important am I, or how much do I need to make sure my patients are following up on this other end. We're spoiled. We take the time with our patients. We know our patients. In physical therapy, it's the same thing. You probably feel like you often know your patients better than their primary care doctors do.
We do. Just because. Oh, well, that's actually something I was going to ask is how long you spend with your patients each day.
So, we do have some routine like hearing aid cleanings that
Mhm.
we kind of just take the hearing aids back and clean them. But we usually spend at least an hour with a patient while we're testing them. And that's not all doing the testing, that's having conversations, doing some counseling.
Talking to family members, I'm
Right.
sure.
And then we bring them back and have, if they need hearing aids, have a good long conversation about what are their individual needs. So it's not just like a consultation or a sales appointment, I
No.
guess you would say. It's a true communication needs assessment. What is your lifestyle? What are your hopes? Because we want to build a treatment plan that is very specific to the patient and to their family and the needs of that person.
And that's just such a critical role for all ancillary healthcare providers, although I
Right.
don't particularly like that term. But
Right.
I'm sure doctors wish that they could spend a half hour or
Oh, they
45
do.
minutes with their patients, but just unfortunately the system, supply and demand, it doesn't work out that way. So we need to be the eyes and ears
Right.
for these doctors. So that's always such a great role that, we can identify these things. And I'm sure, you and your staff are making some jokes before we got on here. It's like, oh, this nurse practitioner thought this, and let's give them a call and let's say, hey, maybe this is a problem. Maybe let's take another look at this. My
Yeah.
opinion, hey, maybe this is something that needs a little bit more, TLC.
Yeah, I had a patient once in a previous job who I had been seeing her for a while, but all of a sudden she started asking me the same question multiple times in the same visit, which
Mm.
hadn't happened before. And so I called her primary care doctor and I said, I just want to address this concern. I've noticed that Mrs. Smith had asked me the same questions a couple times today, and that's a new symptom. Have you noticed this? And she said, well, no, but you know what? We've been meaning to do a cognitive screen on her. So let me call the family and do that. And I knew that that doctor was a good doctor, but just doesn't have the privilege of spending that much time with the patients. And so I take that as a very serious responsibility.
Yes.
We have, and Dr. Donovan as well, that's one of the nice things about being in a private practice too, is we can kind of set our own schedules. I have a couple patients that there's a loving note that says long appointments because I know they take a little extra, but then we just book them a little bit more time and it's just them and we make that time.
That's fantastic. That's
So
fantastic.
yeah,
So I know you have a heart out, so I don't want to take too much of your time.
yeah.
Is there anything that if I gave you the floor, if you had a public service announcement that you would make, is there anything that you would just kind of put out there to the world?
Um, Your hearing is really important. You get your eyes tested, you get your teeth looked at, you should be incorporating hearing into your healthcare and as early as possible. Hearing loss is never normal. It's not normal if you're 7, it's not normal if you're 70. It might be more common, but it doesn't mean that it's not having a big impact on your life. My other uh, big message would be there are a lot of people who sell and fit hearing aids out there, but there aren't a lot that do it the right way. I am vice president of the Audiology Practice Standards Organization. We're board certified. I'm members of a lot of professional organizations, also ones that focus on improving senior lives in our community. And So when we approach everything that we do here, it's really not to do things in the easiest way or to make the most money. And to be quite frank, my prices are quite a bit lower than the rest of the community. But I really look at what is the value of the care that we provide and how can we make hearing care accessible. We now are volunteering at the Lake County Free Clinic weekly, almost weekly. We have a nonprofit part of our practice. We take a lot of the plans that even the hospitals in the areas won't take because we know that everybody, regardless of their income level or socioeconomic status or position in life, deserves high quality hearing health care. We may not be able to afford the best products for them, but they get the same service, those who are poor as those who are rich. And that is where we come from here.
That's very admirable.
Yeah.
I think that's a good spot to end. Thank you
Yeah.
so much, Sarah,
Thanks.
for your time.